Eugene Healy, and I'm Professor of Dermatology in the University of Southampton and University of Southampton Hospital. And I'm going to talk to you about a new approach that we're trying to develop as phototherapy for vitiligo. Now, most of you, I'm sure, are familiar with, especially as the last speaker had gone through guidelines. This is actually taken from a review article by Mara Picardo and Alan Taib, and these are world experts on vitiligo, genetics, treatment, etc. And really what I'm just highlighting in this, it's an algorithm where it kind of basically says, do you have non-segmental vitiligo? And obviously, in terms of treatment, avoid triggering factors. And then if it's not stable, one goes down the sort of oral corticosteroids. But if it's stable, then depending on whether it's limited, whether it's extensive or widespread, there is topical therapies, firstly, and this is just creams and ointments, steroid creams or ointments, or topical immunomodulatory agents, the likes of sort of protopic or topical calcineurin inhibitors. And so these are treatments that suppress the immune system at the site you put them on. And if that doesn't work, one tends to go on to the next phase, which is what we hear they say target UVB. That's basically a bit like the handheld treatments that can be given, the UV can be given with. But if you've got a bit more extensive vitiligo, then it's phototherapy as the sort of narrowband UVB phototherapy, or PUVA, and I'll tell you a bit more about these. And basically that is a treatment which people stand in a whole body cabinet and are surrounded by UV lamps. And if we go on to guidelines, so that was a review article, but if you actually look at the European Dermatology Forum guidelines that came out in 2011, again, it's very similar. You've got this diagnosis, and then you avoid trigger factors. And in the guidelines by the EDF, they actually start with narrowband UVB, and plus or minus the systemic, as in by mouth, or topical, as in creams or ointment therapies, the corticosteroids, the calcineurin inhibitors, etc. And if it's working, one then goes on for 9 months or so in terms of the UVB treatment. The British Association of Dermatologists guidelines that you've heard in the last talk, well, 2 talks ago from the same speaker, but in 2021, you have the topical agents up here, and then you have the narrowband UVB, which is whole body or localized. So what exactly is narrowband UVB? Well, you're all familiar with sunlight. It's not very sunny today, but you're familiar with sunshine definitely during the summer months. And if we look at how much sunshine is actually hitting the Earth's surface. So in this graph, what's the orange bit here, the terrestrial, is actually what's hitting the Earth's surface. And the yellow bit, if you look at sort of the top part of that, that's what actually is hitting the atmosphere. So the atmosphere takes out an amount of the sunlight. It takes out some of the visible, and the visible is what allows us to see. So it's the sort of red, orange, green, blue, etc. in the visible spectrum. Beyond the visible spectrum on one end is infrared, and that's the sort of warm effect that we feel from sunlight. And at the opposite end, down beyond the violet component of visible, is what's called ultraviolet, and that's broken down into A, B, and C. And it's simply broken down into A, B, and C because A can actually get through window glass, whereas B can't, and both A and B can get through quartz, whereas C can't. So the physicists many years ago broke it down into this pattern. But we know that if you look at the Earth's surface, all the UVC is actually taken out by the atmosphere. So only UVB and UVA actually hits the Earth's surface. Now, it has been known for thousands of years that the sun could have effects on skin, and it has been used as treatments back in ancient Egyptian times. But as you can understand, we're not able to switch on the sun in the UK whenever we want. So we need some artificial sources, hence we need lamps. And generating lamps is a bit more challenging than you might think, because actually when you do want to generate a lamp, you have to have basically a bulb. These are normally long sort of tubes which have electricity going in one end and coming out the other, and you have electrons which are shooting across the tube, and they hit a gas in the tube, which then emits the sort of light, or maybe the ultraviolet, and then they often have a lining in the tube which sort of converts it into the ultraviolet. And what this is showing according to the wavelength here, so you'll see here we had the wavelengths, and basically ultraviolet B is around the 300. It can go from, depending on whether you're a biologist or physicist, from 280 to 320 nanometers, or if you're a physicist, 285 to 315 nanometers. But what we're just showing here is how much of the different wavelengths is coming out of different types of lamps. And so this sort of pink one here is the UVA, that when people use PUVA, so this is predominantly UVA that's coming out. This blue one here is the old style broadband UVB, so a lot of it is UVB, it's a bit of UVA. And then this peak here, which is a sort of rust or brownish color, is actually the narrowband UVB. So basically, you know, in the case of narrowband UVB, Philips actually designed a lamp, and it took them about 10 to 15 years to actually get the lamp to work in a way that it would just give out this wavelength. And it was designed this way actually for psoriasis, but obviously it has been trialed and tested in other conditions, including vitiligo. So the standard treatment for people who have more generalized sort of vitiligo is that they will stand in this cabinet. The person would be about that height or so. So it's a full body lamp. It's all around them, and they will come 3 times a week or so for a number of months initially, and then possibly up to a year or so. And that is, in terms of UVB, it's a physical therapy, but what actually is happening is there are biological effects. So it's being converted to have effects on our cells in the skin. And I don't want to go into this in too much detail for you, but this is just the very outer layer of skin called the epidermis, and then the inner layer is called the dermis. While we know that UVA will penetrate all the way down into the dermis, so through the epidermis into the dermis, UVB only really penetrates into the epidermis and down to the bottom or so of the epidermis. Only about 5% will hit the bottom of the epidermis. So a lot of its effects are actually due to the effects it's having in the epidermis. And some of these effects are suppressing the immune system, so they're immunosuppressive. And this is just giving examples. So within the outer layer of the epidermis, we have certain type of immune cells called Langerhans cells. And this is shown them here. And what we've done here is we've taken some skin, a skin biopsy. We've actually stripped off the epidermis now that it's like a mat. So we're looking from the outside in, and all these green areas here are these Langerhans cells. So they're part of the immune system. And really, sorry, I just jumped. Really what their role is to alert the immune system if there is something like an infection or something likely to hurt us in some way or other, trying to attack the skin. But in the case of UV, instead of alerting the immune system, they tend to suppress the immune system. And so this is another biopsy. Again, we're looking from the outside in. Sorry, it jumped again. And what we can see is there are very few Langerhans cells there, and that's because the UV has caused it to migrate out of the skin, and they go to the local lymph glands, and in the local lymph glands, they actually start talking to the immune system's T cells. And this is a naive T cell, so it's basically a baby T cell, and the immune system, the Langerhans cells can say to it, I want you to become a certain type of adult T cell. In the case of a type that's called Th2, if it was a patient who had atopic eczema, it would be saying, I want you to make a Th2 cell. If it was psoriasis, they'd be saying, I want you to make a Th17 cell. If it was a cancer, they'd be saying, I want you to, or a virus, it could say, I want you to make a cytotoxic CD8 T cell. But actually, when UV has been shone on the skin, they are saying, I want you to make a regulatory T cell, and that's a cell that suppresses the immune system. So all these others are ones that excite the immune system. This is one that suppresses the immune system. On top of that, the epidermis produces another chemical called interleukin-10, which is an immunosuppressive type of chemical. It's called a cytokine and suppresses the immune system. So the UV is actually causing suppression of the immune system in the skin and calling in cells, regulatory T cells, to actually keep all the immune cells that are trying to cause the vitiligo in check. It's trying to stop them. In addition, as you know, that the area of skin which has had the vitiligo has lost the cells, the melanocytes, which actually cause, well, they normally produce pigment. And so what happens is the signals from the epidermis are getting down into what's called the hair bulge, which is a part of the hair follicle. And this is where stem cells sit in all of us. And what happens is the UV is calling on these stem cells to start maturing, come out of the hair follicle and repopulate the epidermis. So this is where the melanocytes should be. And you can see on this side, it's just showing there's none there. So what the UV is doing is, in addition to suppressing the immune system, it's calling on the melanoblasts, which are the early sort of stem cell type of melanocytes, to come out and repopulate the epidermis. So that's how a physical therapy is causing biological effects. Now, phototherapy, a narrowband, I'm talking about at the moment, UVB, and I've shown you how we sort of, have the output from the lamps in order to give us narrowband. And it's used in psoriasis. It's actually NICE approved as a treatment for psoriasis. I've already shown you that the British Association of Dermatology and European Dermatology Forum guidelines recommend narrowband UV as a treatment for vitiligo. It's used by most departments in the UK. So I'd say almost every dermatology department in the UK would have at least one of these narrowband UVB lamps. In our own department, we have 5 different cabinets that can give narrowband UVB. But it does require attendance for up to 3 times a week for up to 10 weeks if it's psoriasis, or 3 months and longer if it's vitiligo. And so that's quite a commitment. The other issue is that there are a number of hazards of UV, and in someone like myself who's fair-skinned, sunburn is a definite hazard for the likes of me if I get too much UV. Photoaging, which basically is just sun damage, sun aging that happens in the epidermis and the dermis, and it's quite visible. You can see that this skin here just doesn't look like a newborn baby's skin anymore. It has had aging, but it has had a lot of UV, which has caused this photoaging as well. And then if one is very unfortunate, one can develop skin cancers from UV. The most common type of skin cancer is basal cell cancer. That isn't too nasty, which is fortunate because it's the most common one. But squamous cell cancer and melanoma are more nasty cancers, and they can actually be fatal in a number of cases. And while there's no evidence yet that people who are treated with narrowband UVB for vitiligo are developing these cancers over and above the sort of what would be expected in the normal sort of population, there is recent evidence to suggest that some of these precancerous lesions, so these actinic keratoses, there's no ordinary name for them, I hate to say. Sometimes they're called solar keratoses, but basically these are sun damage, and they are potential precursors of squamous cell cancer. So not all of them will go on to skin cancer, but some of them may. And it has been shown that actually these are more common in people who've had 200 or more narrowband UVB phototherapy sessions. So every time one goes into the machine, one is having an exposure to narrowband UVB. And you're having it 3 times a week, and bearing in mind that if you have one course, you may have for up to a year. So that's 150 or 156 if you get it all the weeks, exposures already. So you have 2 courses in your life, and you're already going more than this. And the problem is that actinic keratoses being precursors to these types of cancers, we don't really know at the moment whether there is a risk that people will develop cancers later on. Now, this is not to worry you, it's just letting you understand why in the way we're thinking, we're saying, how do we improve the treatment for vitiligo as well as other conditions and reduce the risk of skin cancers and damage, etc. in the skin. The other issue which you are probably familiar with is that UV can cause repigmentation, but it doesn't always appear at all areas of the vitelliginous area. And sometimes, as in this case, it actually can be darker than the surrounding skin. This is taken from the NHS website, actually. And so we know from a number of studies, which I show a couple of them here, where if people get the patches coming back, but they're more pigmented than the normal skin, while doctors might say, oh yeah, this is repigmenting, the patient may not be happy with the cosmetic result. And we know that also it can tan up the normal surrounding skin, and this kind of hyperpigmentation of the non-vitelliginous skin, also for some patients, they feel it makes the vitiligo more noticeable during the treatment, and possibly, if it's not completely successful, actually more noticeable in general. So again, is there a way we can get around this? Now, this is just showing a study which has been published in JAMA Dermatology. So this is a good dermatology journal, and it's a systematic review and meta-analysis. And just to explain that to you, a systematic review is where you look at all the publications in the literature way back in time up to the present, and you collate them all together, and you then analyze them all together as if they were kind of similar to one study. And this is one of the strongest sources of evidence you can get in modern medicine. And so what this study has shown is that if you just look at 3 months, 6 months, 12 months, and we're looking at narrowband UVB here, the reason I should just mention as an aside, we don't use PUVA much, is PUVA is more carcinogenic. It's more likely to cause cancers than narrowband UVB. So by and large, we tend not to use PUVA except in rarer occasions. But in terms of, if you look at the 3 months, 6 months, 12 months, you can see there are some people who do very well. They get greater than 75% repigmentation. As you know, you'd want 100% repigmentation, but as a bar, they've looked at 75% in this meta-analysis. And there are some people who are getting greater than 75, some people who are getting greater than 50, and some who are only getting greater than 25. And if you look at this graph here, then again with narrowband UVB, you're having, again, similar amounts of repigmentation, whether it be 75, greater than 75, greater than 50, greater than 25. And it varies. So the sort of greater than 75, you can see the face and neck's more likely than the trunk, than the extremities, and the hands and feet are very poor. And that may be because there's fewer hair follicles. But this whole, sort of meta-analysis, when you begin to look at it, you begin to say, well, is it that you need different doses of UV at the different body sites? So maybe when you're in lamps, full body cabinets, you can only give one dose, maybe one size doesn't fit all, so to speak. So we actually put in a grant a couple of years ago to NIHR. It was actually called the AI Artificial Intelligence in Health and Care Award, and we were fortunate enough to get the grant. And NHSX, which is the sort of computer or IT side of the NHS, and NIHR were involved in the grant. And this is just telling you what was funded in that grant. It's basically developing automated techniques for the treatment of psoriasis via targeted delivery of laser light. And the aim here was to reduce the risk of skin cancer in adjacent skin caused by the current treatments, where the unaffected as well as the affected skin has often been exposed to UV. So as I said, in the full body cabinets, the whole of the body is getting exposed. And in conditions like psoriasis, you would say, well, why do we need to do that? This is just showing psoriasis here. So you can see there's lots of normal skin. So, is there any way we can get around having to irradiate all the skin and just irradiate the areas that are affected? And obviously we began to think of vitiligo in a similar sort of way. And so what we're trying to do is we're trying to develop an approach where we have a laser which would have UVB, and using some, whether it be robots or scanning mirrors or whatever, we just hit the vitiligo and we don't hit the normal skin. And theoretically, when we actually are treating the patient, then if it repigments, then we may just be ending up hitting the part that still has vitiligo on and not hitting the part that has begun to repigment. And the aim of this is to try and treat just the area that needs to be treated, but also not cause increased or too much pigmentation of the surrounding skin or the repigmented area. And what we want to do now is we want to train up the artificial intelligence. It's called a neural network. So our brain is full of neurons, and there's a network in there. So this is sort of the computer neural network, and we want to train it on photographs of vitiligo. And then when we've trained it up, we want to test how good it is at actually identifying the vitiligo in other unseen photographs of vitiligo. And this is where we're at, and this is why I want to talk to you today about this. For the future, we definitely want public and patient involvement. We have had the Vitiligo Society involved in this sort of venture so far, which is great, and we're really grateful to the Vitiligo Society for that. We obviously want more patient and public involvement. We want to ultimately get to a stage where we can do a pilot study on single lesions of vitiligo to show that the phototherapy device that we do produce will actually be effective, and then do a clinical trial on people who have multiple vitiliginous lesions on their skin in order to show hopefully that it's effective and that we're only hitting the relevant areas and we're not causing increased pigmentation of the surrounding skin, etc. Now, you know that in terms of psoriasis, well, you probably know it's a lot more common than vitiligo, and our neural network is currently greater than 95% accurate for psoriasis at identifying the psoriatic lesions. But vitiligo is far less common than psoriasis, so we definitely need your help in this area. And so we've set up a vitiligo study website. Here we've called it AMATS, which is Artificial Intelligence Mediated Assessment and Treatment of Skin Disease. And so I've put up here, hopefully you can see this, because on my screen, there's a stop share in front of it, but hopefully you're seeing https://aim.sutton.ac.uk/vit/. And I'll show you this again in a short while, but if you want to just take a note of this, or indeed maybe the Vitiligo Society, I'd be happy to send this out to all participants. But what we have in the study website is we talk a little bit about vitiligo. I'm sure lots of you know lots about this condition. And we talk about artificial intelligence and how we've developed a way to train the computer to recognize vitiligo from photographs of skin affected by vitiligo. We have done a little bit in this, but we're not anywhere near the 95% at this stage, which is why we need photographs from people who have vitiligo. And as we say that we think the use of artificial intelligence may allow ultraviolet light treatment in the future be directed only to the vitiligo. And in this research study, and if I go to the next one, it just highlights we would like people with vitiligo to submit photographs of vitiligo so that we can train, well, we can use artificial intelligence to train a computer that it can recognize and score the severity of vitiligo with high accuracy. And that's a precursor to developing the UV phototherapy that will just target the vitiligo. So this is the team, and you know a little bit about me, but just to tell you, I'm Professor of Dermatology, and I've been a consultant dermatologist for over 35 years. Sorry, I've been a doctor for over 35 years and a consultant dermatologist for over 30 years with clinical experience in dermatology during that time. I've done an amount of research and I've worked on skin pigmentation. I haven't done a lot on vitiligo, but we were the group who found the gene for red hair and fair skin many years ago. A lot of my work has been on skin cancer. I do genetics, I do immunology, I do molecular biology, I do almost anything that I can do. I've worked on ultraviolet radiation and then various other skin diseases, etc. And I've done lots and lots of different things over the years in my professional roles. I'm currently chair of the UK Translational Research Network in Dermatology, which is basically BAD grouping, British Association of Dermatology grouping, where we're trying to actually ensure that we do research that actually translates into improving care in the clinic. I've been an expert committee member for the NICE guidance on sunlight exposure risks and benefits. I've been a board member of the European Society for Pigment Cell Research for about a decade. I've done various other things, president of the European Society of Dermatological Research, various other things, etc. So I'm a clinician and an academic. Ben Mills, he's the Principal Research Fellow in the Optoelectronics Research Centre in the University of Southampton. And this is a top research centre in terms of understanding sort of lasers, the fibre optic guides, artificial intelligence, etc. And it's world renowned for this. And so his research focuses on artificial intelligence and deep learning, which is when you have multiple neural networks tied in together. He's doing it in laser-based processes, and it's including for medical use, but he's also done industrial manufacturing. So if you want machines to start making things and cutting them with lasers just to make things of an exact same size, Ben has been involved in that sort of research that underpins that. And then he's also involved in laser-based manufacturing of medical devices. And he's also a member of the Alan Turing Institute, which is where all these boffins who know lots about artificial intelligence and computers, etc., meet up. Rob Eason is Professor of Optoelectronics, and he's got over 40 years experience in lasers and various other things, laser material interactions, ultra-short pulse laser techniques, etc. He's actually received the Royal Society Millennium Award for Public Understanding of Science. So he's great at just giving talks and explaining, quite challenging physical concepts to the public in a fairly easy to understand way. And he's a founder and director of a medical device manufacturing spin-out company called Highfield Diagnostics. Mahasan Naranjan is Professor of Electronics and Computer Science in Southampton. He's over 30 years experience in research on artificial intelligence and machine learning. And he goes into the deep, what we call the algorithmic sort of component. So he's the sort of guy who writes these, sort of pages and pages of programs in order to direct computers to tell them what to do. He's worked on speech and natural language. So basically, when you talk into your iPhone or in whatever phone, it's his sort of research which has allowed that to happen so that it recognizes what you're saying. And his recent research is on computational biology and biomedical problems. So he's looking at image analysis for various diseases, so X-rays, etc., and understanding regulation of cells and proteins in disease situations. And then Joseph Scott is an NIHR academic clinical fellow. He's a specialist registrar in dermatology. So Joseph is basically me, is something like 25 to 30 years ago, where he wants to be a clinical academic, wants to be a future professor, wants to undertake both clinical and research. And he's focusing on this study, the AMATS PREVAIL for psoriasis and vitiligo. That's his main research topic. And he's actually training in artificial intelligence. So while he's a clinician, he's seeing patients, he's doing clinical research, he knows about UV, he's actually has learned sort of the programming language Python in order to be able to do the sort of stuff that Ben and Naranjan do as well. And he wants to continue this and get a fellowship in order to be able to undertake this study on vitiligo and psoriasis. So that is on the website, apart from Joe's a later edition. But if you go onto the website, you'll see, again, what I was telling you about the background, etc., and what the research is about. And then it says, if you're interested, start here. And if you click start here or click read the information leaflet, you'll get brought onto the information leaflet, the participant information leaflet. And I'm not going to, sorry, it's jumped again. I'm not going to show you all of this because you can read it, hopefully, when I show you the website link again. But it asks, it tells you what's the purpose of the study. It tells you what will happen if you take part. It's basically, you're in control. You take some photographs if you're interested, and you submit them through the website to us. And you can trim them, you can do whatever within reason, so that they're large enough that we can still see something, if you know what I mean, clearly. And then when you go down to the end of the patient information leaflet, if you press next, then there's a consent form, and we've made it fairly easy. I mean, you read through them, but you consent to items 1 to 8 above, which is just basically saying, you're happy enough to participate. There is an optional component as well, where a number of people have been happy to also say, yeah, I'm happy for the photographs I use, because they're not going to I'm not going to be recognized from them. I'm happy for them to be used in publications or indeed in presentations such as this one that I'm giving to you today. And so we also then, when you come down to the end of the consent and you've agreed to consent, if you don't agree to consent, obviously it doesn't shift you on, so you have to agree. This is not me trying to twist your arm. This is just telling you how the website works, because we need to know that people are happy to submit the photographs. I should just briefly go back. We even have things that, we want people to be 18 years old to 80 years old, and also that the photographs they're submitting are of themselves, of their own skin. So it's not somebody taking a photograph of someone else and submitting it against their will. And we give a bit of information on how to submit photographs. So, how to take good quality photographs, etc. Most of you probably know this, because most people have phones, etc., cameras in it. But again, just simple things like try to avoid shake, try to choose a plain background, etc. Try to make sure that the photograph contains at least one full vitiligo lesion, but you can also give us others that contain a number of lesions. And then there's a place to submit your photographs. And I've not done this on my phone yet, but I'm told that this also works on phones, etc., and on iPads, as well as on desktop and laptop computers. So this is just to remind you of the web address, if you want to take it down. And the plea to you is help us to improve phototherapy for vitiligo by submitting your photographs of vitiligo via this website, please. So I'm happy to take questions, but I accept it might have been a slight whistle-stop tour, but I just wanted to teach you a little bit about sort of where we're coming from, how UV works, etc., and why we want to try and do it in hopefully a more effective and safer way in the future for vitiligo, in the hope that it will give better cosmetic results. So I'll unshare my screen.
Thank you so much for that.
No, that says share. So how do I unshare? What do I do? X?
I'll sort it out.
You can see I'm a computer buff, can't you? Yes.
Thank you so much for that presentation. It's really helpful to understand in more detail what is a really common treatment that people embark upon with vitiligo, particularly in the early stages. I'm conscious of time, but what I will do is just ask one question, which has come from our patron, our society patron, Dr. David Roger, who's asking you, what extent do you think the effect of phototherapy in vitiligo is a systemic one rather than one localized solely to the depigmented patches?
And David knows that's a difficult question to answer, but I suppose that if we think of the use of topical steroids, topical calcineurin inhibitors, and even the JAK inhibitors that are coming on topically as well, we suspect they're not really having a systemic effect. So I think there is a role that local treatment may well work locally. I mean, we definitely know that Langerhans cells, because they come from the skin and they promote the production of Tregs, and they actually, because Langerhans cells come from the skin, they put on an addressin, which is a little marker that makes the actual Treg go back to the skin. I mean, there is some evidence that UV, if you give people enough UV on total body areas, you can have systemic effects. It's unclear how much that is absolutely necessary. And in reality, we're quite sort of fluid at the moment in our thinking on this area, that you may have a scenario where if someone had, for instance, lots of vitiliginous areas, you might decide that you'd start them in a cabinet, in a narrowband UV cabinet, and then sort of hit the remaining areas with the localized. I mean, anything is possible is what I'm saying, but I think we'll only know, I mean, we definitely know that the localized UV lamps that people use are having an effect as well. And we know the excimer laser, which is localized, has an effect as well. So I think, both answers are correct. Yes, it has a local, yes, it has a systemic, but what it has in each individual at each part of their skin, difficult to know. Does that explain it enough, David?
Super, thank you. Yeah, I think it was a helpful question to explore an often asked question, I think, and just to try and to help people to understand that it's not very clear at this stage, but we are doing our best to understand it. I'm conscious of time, but I will just ask one more sneaky question, Eugene, if you have a minute. So there's a question from Ayat Al-Mclaffy, who says, how common is it to depigment again once you stop the UV sessions? And on average, in what number of the sessions do patients see good results? So I think you had a little table on this around a certain number.
Yes.
25.
It was basically, you had so if I go back to the systematic review and meta-analysis, and you could see that there were variable numbers of people who had, 75%, 50% or 25% pigmentation. I don't know if it's possible to do the share screen, or if you're able to share it again. But so we know, even when people have gone, sort of 9 months to a year, that some people won't repigment, unfortunately, at various sites. But we also know that vitiligo is an immune-mediated disease, and we don't believe that our immune system is, if I say completely correct, so we think there's a balance in the immune system. We think that in our normal skin, we have immune cells that are ready to attack, and we have immune cells that keep them under control. So we all have regulatory T cells in our body, in our skin, and we also have the CD4s and CD8s, which are the attacking ones. And so it's that balance that keeps the status quo. And so, again, we don't fully understand why the vitiliginous skin, the immune system starts attacking it, really. But, the trauma can sometimes, co-polarization, as we call it, stress may do it, etc. We know various sort of, potential for infections and various treatments that are sort of targeting things like melanoma, for instance, can do. So there's a whole gamut of things which can actually provoke it again. So we can never say that once we've treated you, you'll never have vitiligo again. It's a balance. But again, if something works one time, the hope is it'll work the next time if it is required.